Thank you, Francine, and thanks to everybody for keeping present in this meeting. And I think I will try to overview with you some of the data that emerged over the last 3-4 years regarding another pathways that have been explored in lymphoid diseases. That's my disclosures. So PI3 kinase is a complex molecule that regulates different pathways, and although it's known for many years, there are clearly different isoforms of the PI3 kinase which are summarized here. We will dedicate this presentation mostly to the PI3 kinase delta, which is expressed in leukocytes and which is involved in B-cell signaling and in B-cell development and survival. But I will also touch a couple of data more recently presented, partial data regarding the inhibition of the other isoform or combinations. Clearly, there are some experimental data, and there is very nice reviews 4 years ago not by David Fruman, who is a scientist who dedicated this time to explore the role of PI3 kinase delta in the B-cell physiology. Clearly, although there are a couple of molecules that play a role just downstream of the BCR, PI3 kinase delta is just below this initial component of the signaling pathway and is also involved in the regulation of signal coming from BCR signaling. It also is involved in signaling through the TLRs, other accessories molecules such as CD19. Interestingly, it also plays a role in some of the molecules that are involved in the survival of B-cell with cytokine signaling such as BAFF or IL-4, TNF, as well as some of the molecules involved in leukocyte migration such as different chemokines. So one of the first compounds that was explored in this field was Idelalisib, which is a highly selective oral inhibitor of PI3 kinase delta. As you can see, its specificity against the different isoform, which is shown here. This is a very specific delta inhibitor of PI3 kinase. So I will present you the initial clinical experience with this compound, which was the most advanced, which initially was developed by a small company called Calistoga, and then called GS1101 or Idelalisib, and now marketed in the US and in Europe. So the first initial data that were presented and which has been reported now in 3 distinct papers in Blood last year in mantle cell, indolent NHL, and CLL have clearly shown the proof of principle that this drug was active in inducing lymph node response in different subsets of B-cell malignancy. You see here on the left panel some responses in mantle cell, in the medium panel in different indolent NHL, which includes follicular, small lymphocytic, and Waldenström disease, and on the far right panel, CLL patients. Just one word about MCL, which I won't come back on this subset of lymphoma. There is, as you can see, some responses, and this is further amplified in the Brad Cal paper in Blood in 2014. But clearly these responses don't last very long, I think about 2 months or something like that. And it has been clearly shown that after inhibition of PI3 kinase delta in mantle cell, there is the activation or the rescue of the cell by PI3 kinase alpha, explaining the escape of this tumor cell to the inhibition of this pathway. Based on this result and with a very good nodal response sign in CLL, a couple of studies have been performed. This is more detailed results of the experience of Idelalisib in CLL, showing in the 4 graphs the reduction of the lymph nodes on the 2 upper graphs, either as a waterfall plot or by bidimensional measurement. As you can see, with increased doses of the compound, there was a more marked reduction, which led to actually the optimal dose being 150 milligram twice a day. As you can see on the bottom left, there was an increase of lymphocytosis, and I will come back to that, something that has been seen also with BTK inhibitors. While on the far right graphs, you can see that patients that were on treatment with this PI3 kinase inhibitor actually experience an improvement in some heme parameters, such as hemoglobin level and platelet level, something that is also seen with other kinase inhibitors in patients with B-cell malignancies. Well, this lymphocytosis is clearly explained by the activity of the compound in not only tumor cell, but also some cell from the microenvironment. And you can see here on the graph a nice schemes that try to summarize the data that have been experimentally obtained by trying to understand the role of PI3 kinase delta inhibition in the different signaling of the homing of B cell. It's thought that CLL cells circulate, but as you know, develop in the microenvironment of lymph nodes, and the signals that lead to the survival of this cell appear to be abrogated within the lymph node, leading these cells to migrate and to circulate again, where they will eventually either survive or die. Well, based on this result, one of the leading trial using Idelalisib was the registration trial, which was published last year in the New England Journal of Medicine by Richard Furman and many other colleagues, which actually investigated the combination of Idelalisib plus rituximab with a standard dose of Idelalisib and rituximab given by 6 to 6 months versus placebo and rituximab. This was a primary study, 116, and I would like to point that there was an extension study with crossover for patients that failed the placebo arm and that were also put on Idelalisib rituximab. The curves have been shown several times and probably yesterday morning, but clearly there was a very significant benefit of the combination of Idelalisib plus rituximab as opposed to rituximab only. This is shown in terms of progression-free survival, but also in terms of overall survival, as shown here, with quite impressive data regarding this population of patients that have been treated with different options before. As you can see from these forest plot graphs, the activity was substantial in any subset, including older and younger patients, male and female, but also patients with 17p deletions or other abnormalities such as IGVH unmutated pattern. The update, which was presented by Dr. Sharma at ASH this year, including the extension study, so patients that crossover, is quite interesting regarding overall survival curve, which is shown here, clearly indicating that there was a benefit which was maintained in terms of overall survival with a hazard ratio of 0.34, highly significant also for patients, the subgroup of patients with unmutated IGVH genes, as well as those with 17p genes, maybe less clear for patients with 11q. Well, how is this treatment tolerated? And I think there are some information that came up already from this trial, but I will spend a little bit of time later on with the other trials. Because in this randomized trial, as you can see, and these are the data from the interim analysis as well as the update, there were already some apparent side effects, which include diarrhea and colitis, which represented 6% of grade 3 colitis in a patient treated with Idela and rituximab, going up to 16% in this patient at the updated analysis. As you can see, initially there were no kind of colitis seen in the patient in placebo. Some were seen in the updated, but it may represent some of the patients that have been further exposed to the drug. The other adverse effects were common, very few grade 3, some fatigue, some asthenia, but that's quite balanced. There was also some signals regarding the possibility of some lung effect. I thought it was quite equilibrated between the two arms and the study, and this is something infectious lung effects that are seen in many patients with this kind of disease stages. There are some specific lab abnormality which are encountered with all PI3 kinase delta inhibitors so far, which is the elevation of transaminase, ALT and AST, which can be raising up to grade 3 and 4, and which are encountered here in this trial in a relatively minority of patients, but are more frequent, as you can see later when Idelalisib is used as a single agent in other subsets. A smaller incidence, higher incidence of neutropenia, but as you can see also reduction of the number of patients with anemia or thrombocytopenia. As we have seen with ibrutinib and presented by Simon Rule earlier, there was also a study in frontline patients over 65 years old with a combination of rituximab and Idelalisib. And these curves that have been reported by Susan O'Brien at ASH show very impressive results in the frontline setting, including in patients with 70P, which, as you can see, had little, if no event, and also survived quite extensively. The absolute lymphocyte count increase was obviously more abrogated by the combination of anti-CD20 plus Idelalisib. If we go back, however, to side effects observed in this trial, you can see that the incidence of grade 3 diarrhea and colitis appeared to be substantial, up to 40% in this patient, as well as the incidence of pneumonia. And I think this diarrhea and colitis are probably explained by some immune-based mechanism regarding the inflammation of the GI mucosa, and are really probably specific of the activity of this drug. They need to be clearly monitored and need early intervention by suspending the drug and putting the patient on steroids. If you do that, some patient may recover. You may potentially reuse the drug at lower dose very cautiously. But if the patients are maintained on drug, you may have devastating diarrhea in patients, with patients being really debilitated, and some patients may ultimately have an unfavorable outcome. Although no direct death was related to this event, there are clearly some patients that have been really hampered by this side effect. If you come back to lymphoma, based on the early activity seen in those patients, the company actually designed a trial trying to assess the efficacy and safety of Idelalisib as a single agent in a difficult population to treat of refractory indolent non-hodgkin lymphoma, which were defined as double refractory both to alkylating agents and rituximab. Well, the population included about 58% of the patients with follicular, but also other histology. As you can see, 1/4 of the patient had bulky disease or elevated LDH. Some also of the patient had impaired hematological parameters as study entry. I think, as you can see, all patients have been previously exposed to rituximab and alkylating agent, most of them to bendamustine, but also to anthracycline and some with purine analogs. And the refractoriness to prior therapy was an eligibility criteria, but as you can see, about 70 to 80% of the patients have been refractory to combination of BR or R-CHOP or RCVP, and 3/4 of the patients were really refractory to bendamustine, and 80% again were refractory to at least 2 regimens, and 90% to the last regimen. So this is really patients that don't have necessarily good options at the present time. The response rate, which has been published in the New England Journal of Medicine also 1 year ago, was clearly interesting, raising to 57%. Ajay Gopal actually presented the update of this data at ASH last year with no marked difference, maybe a very slight increase in the complete response rate. And the complete response rate, as you can see, was rather low, 10%. It was mostly partial response that was observed, and some minor response, including some in patients with Waldenström disease. Interestingly, and this is not shown on this slide, most of the responses were seen at early evaluation, which is at 2 months. Also, some of the patients did improve their response with time, maybe a phenomenon that is less marked than what we see with ibrutinib, but which is consistent with the activity of this family of drugs. This shows the lymph node response by the different histology. You can see the response in follicular lymphoma, in small lymphocytic lymphoma, as well as marginal zone, and some responses in Waldenström diseases based on different evaluation criteria, obviously. The duration of response is, you may say, depending on the way you see the things, limited. It lasts 1 year. I just recall you when rituximab was first developed in population of patients that have never been exposed to this drug. The duration of response of rituximab was also of 12 months. So I think this is still quite an encouraging result, despite the fact that some of the patients had progressed and that this is only 1 year. Again, adverse events were similar here with some diarrhea and colitis, as you can see, up to 20%, probably less infections that was seen with CLL patients. Again, some transaminitis, which actually concern almost, as you can see, 15% of the patient with grades 3 and 4. That's easily manageable. It appears after 1 or 2 months of treatment. You withdraw the drug and you reintroduce the drug 2 or 3 weeks later with a lower dose. And most of the patients in which this has been tried were able to resume treatment and continue. So the summary for the study in lymphoma of Idelalisib is that this is an active drug in a highly refractory population, with an encouraging response rate, a duration of response at about 1 month, a safety profile which is manageable, as of caution should be done, and this led to a couple of trials which are presently being conducted of combining Idelalisib with rituximab or Idelalisib plus bendamustine rituximab. I think the last one trial is almost complete for accrual, while the other ones is still a little bit leading behind. But I do think that we'll get some result in the next year of this large phase 3 trial, which will probably better define the role of this drug in the management of indolent lymphomas. I should like to say one word regarding other PI3 kinase inhibitors. The first one to mention is Idelalisib, or IPI145, which was developed by a small company called Infinity, but now I think in collaboration with AbbVie, if I understood well, which is a dual inhibitor of PI3 kinase delta as well as PI3 kinase alpha. What is interesting regarding PI3 kinase gamma, which is interesting regarding PI3 kinase gamma is the expression of this isoform in T cells, and leading the idea that this compound may be active in B cell malignancies as well as T cell malignancies. On the other hand, the inhibition of the PI3 kinase gamma may lead to potentially side effects by the inhibition of T cell function in this patient. So the results have been updated by Jan Flynn last year at ASH regarding the initial phase 1-2 study in patients with relapsed refractory indolent NHL, defining a dose of 25 milligram BID as the optimal dose on this patient. As you can see from these graphs, there were some sustained effect in patients in this early trial, with actually half of the patients with this dose being progression-free on 1 year, and an overall response rate of 73%, including actually 3 patients with CR. The development of this drug in indolent disease is being pursued by the company with a clinical trial in double refractory patients, very similar to the one we have seen with Idelalisib, as well as a combination trial in patients with relapsed disease, a combination of IPI145 together with rituximab, which has been started some time ago. There was also some responses in patients with CLL, and these drugs seem to be active. Although you can probably guess from these graphs that it may be a little bit less active than some other drugs in the field that we have already discussed during this session. Quite interesting was a very preliminary result regarding the activity of this drug in T-cell lymphoma, and some of these patients have responded to this drug. Although it's a limited experience, it gives a signal that to further explore this compound in this subset of patients. I would like just to touch down with now 2 other PI3 kinase inhibitor. One which is a pan PI3 kinase inhibitor, which is called Idelalisib, which is developed by Novartis, which has entered in clinical trials 3 years ago. This is a broad inhibition of PI3 kinase, so not only gamma and delta, but also alpha and beta. which are involved in signaling and in signaling of different pathways, including the insulin growth factor and other growth factors. The clinical trial that was presented in a poster by Anas Younes last year at ASH was the result obtained in a cohort of patients with DLBCL, follicular lymphoma, and mantle cell. I should say that you can immediately see from this waterfall plot that this drug appears a little bit less effective. And as you can see, the number of response achieved in DLBCL is limited, 11%, 25% of response in follicular. This is a difficult drug because it has also some neurological side effect potentially, and I'm not sure that the development of this drug will move forward. Another drug that is being still on development with the PI3 kinase pathway is Idelalisib, which is a drug developed by Bayer, which is a double inhibitor of the delta and the alpha isoforms. It has demonstrated efficacy in preclinical model, and some preliminary efficacy results, which were presented 2 years ago by Martin Drailing and co-workers, have shown some quite interesting signal of efficacy in a subset of different patients with hematologic malignancies, including some patients with diffuse large B-cell lymphoma that had underwent into CR, a few response in patients with T-cell lymphoma, some responses in patients with mantle cell. Again, the dual inhibition of delta and alpha may explain this activity, as well as some activity in follicular lymphoma or maybe in patients with CLL. The difference between this drug and all the other drugs we have discussed is the fact that this drug is actually administered IV, so it's a completely different drug, but also like the side effects which are related to the inhibition of the alpha pathway include hyperglycemia and hypertension, which can be something not very easy to manage in patients which may have comorbid conditions such as patients with heme malignancies. Although you may say that we use everyday corticosteroids that also can provoke this kind of side effect. Where this drug will go in the future, I don't know. The company is trying to continue development in combination with other agents in different subsets of heme malignancies, but it's only at the present time where this drug will develop. So in summary of this presentation, we have the proof of concept that several drugs that target the PI3 kinase pathway, and specifically the PI3 kinase delta, are effective in patients with different lymphoid malignancies, with quite different spectrum of activity and toxicity profiles according to the specificity against the different isoform. Clearly, the more advanced drug is Idelalisib, which is a PI3 kinase delta inhibitor. It was recently approved in the US and EU based on the trials that I presented in double refractory indolent NHL or in relapsed refractory CLL in combination with rituximab, as well as in first-line CLL in patients bearing 17p or p53 deletions. However, this drug has a toxicity profile which imposes a careful management of patients, especially in terms of colitis, and I think that's one of the messages. I think it's quite easy to manage the transaminitis, and I'm not sure about the pneumonia or neutropenia events, but the GI effect is something we should be careful. Although I did have some patients that were maintained on Idelalisib for more than 2 years without having any of these side effects. At the present time, there are multiple trials that are evaluating the combination of these different drugs with rituximab, with other anti-CD20 antibodies, with chemotherapy, with other kinase inhibitor, and I think that's quite an interesting field. It was already alluded to that Gilead has acquired one of the BTK inhibitor and developed Idelalisib, and combination trial combining these two agents will start. However, we have to be a little bit cautious. This company also had a SYK inhibitor and tried to develop a clinical trial combining Idelalisib with this SYK inhibitor, which was interrupted because of pneumonitis, an effect which appeared to be linked to the inhibition of the mTOR pathway, leading to some quite severe side effects. So I'm not sure at the present time how this double inhibition of kinase will work in clinical setting and whether this will go. There are probably other targeted agents which can be also associated. And to finish with another prospective paper. There was recently a paper showing that among the mechanism of escape to ABT199, which was presented elegantly by John Seymour, the activation of the AKT-mTOR pathway is one of the mechanisms of resistance that can appear in vitro when tumor cells are exposed to ABT199, and that appears to be dependent on the PI3 kinase pathway, and I don't have the time, or maybe it's too far to develop the graphs and the Western blot presented on this slide, but they show elegantly that by combining the two drug, Idelalisib and ABT199, you rescue some of the mechanism of resistance. So I can thank you for your attention. I will be happy to try to answer any questions.